appropriate situation. And many of the doctors who got trained with us, they have told that they are yet to find an ideal patient to start methadone. So it is also important for us to understand for which patient the methadone would be appropriate. And another important thing is that when the patient is on another opioid, how we can convert it into methadone. And if you look at the literature, there will be a lot of methods by which you can convert to methadone. But what would be a good method and a simple and easy method to convert it into methadone? So we will cover these aspects today. And first of all, the pharmacology. Can anybody tell me how or on which receptor the morphine acts or fentanyl acts?
Mu receptors.
Yeah, it's mu receptor agonist, isn't it? Both methadone as well as, morphine as well as fentanyl are mu receptor agonist. But in case of methadone, there are some difference. Actually, methadone is an isomer of two mixtures, S-methadone and R-methadone. And it acts on all receptors as agonist. Okay, it acts on mu, kappa, and delta as opioid agonist. So we can understand that in addition to the action on mu, it also provides analgesia due to action on delta receptor as well as kappa receptor. And it is an NMDA antagonist as well. So it is an N-methyl D-aspartate receptor antagonist. So which is the other medication you know that has good NMDA antagonistic property? Anybody? Which other medication has NMDA antagonistic property, which is commonly used in anesthesia?
Baclofen? No.
Not baclofen. Anesthetist commonly used.
Okay.
Yeah, it's ketamine. It's ketamine. Yeah. So ketamine is another useful NMDA antagonist, which is used to treat chronic pains. Then it also inhibits the reuptake of noradrenaline and serotonin. So which is the other group of medication which has the action, this action, serotonin and noradrenaline reuptake inhibition?
Duloxetine, SNRI.
Yeah.
No, the
Yeah, tricyclic antidepressant and SNRI also. Duloxetine also inhibits serotonin and noradrenaline reuptake. So tricyclic antidepressants as well as SNRI has this action. So the last action is it causes HERG blockade. HERG means it is human either agogo related gene. Okay. So this is a gene present in smooth muscles and it is abundant in myocardium. So when this gene is blocked, it causes torsade points. So these are fatal arrhythmias which can lead to death. So you can see that the first three properties or the mechanism of action, these are beneficial, but the last one is something which can cause serious side effect, including mortality. So this is the mechanism of action of methadone. And let's look at the clinical impact due to various properties of methadone. So because of its action as agonist on opioid receptors, all of us know that it can produce analgesic effect. But because of that itself, it can also have some side effects, which is common for the opioids. It can produce constipation, urinary retention, edema, pruritus, in overdose, respiratory depression. All those side effects which are similar to other opioids. And here you can see there are 4 patients, patient A, B, C, and D, and they are consuming a fairly large amount of equivalent doses of morphine. You can see one of the patient is patient A. He is on about 12,000 milligram of morphine, whereas patient D with 1,000 milligram of equivalents of morphine. And can anybody tell me what is meant by tolerance?
You have to increase the dose. As you continuously taking, the dose has to be increased for it to be effective.
Yeah, to get the same effect, you have to continuously increase the dose of medication. Suppose a patient is on morphine 10 milligram and patient is getting pain relief of now pain score is 2/10. Maybe after some time, maybe after 1 month, you have to increase the dose to 30 milligram to get the same pain relief of 2/10. Maybe after another 1 month, it may go up to 40, 50. So that's what tolerance means. Okay, to get the same effect, you have to continue to increase the dose of medication. So here there are 4 patients who are on fairly large amount of equivalent doses of morphine. Okay, so all of these patients are started on 10 milligram of methadone 8 hourly. That is total of 30 milligram of methadone per day. And all of these patients got good pain relief. So you have to understand that a patient who is taking 11,000 milligram or 12,000 milligram of oral morphine equivalent, and the patient who was taking 1,000 milligram of oral morphine equivalent, all of these patients was started on equal doses of methadone, and they got good pain relief. This is because NMDA receptor is involved in the development of tolerance. So when you added NMDA antagonist like methadone, that NMDA tolerance is reversed. So this is one of the important property of methadone. So methadone can be used to prevent as well as reverse the tolerance. And you also know that NMDA antagonist will be helpful to treat neuropathic pain. The third impact or third property is inhibition of reuptake of noradrenaline and serotonin. So we all know that tricyclic antidepressants are generally used to treat neuropathic pain. So methadone will be helpful to treat neuropathic pain, but it can also cause another syndrome known as serotonin syndrome. This is not only a problem with methadone, but also any other medications that can cause a serotonin inhibition. Like even tramadol can cause the syndrome if you use tramadol along with the medications which I have charted out below. So there are medications like fluoxetine, sertraline, paroxetine, clomipramine, MAO inhibitors. If these medications are used along with methadone, the risk is high. The risk of producing serotonin syndrome is high. But it's low with mirtazapine, nortriptyline, etc. I haven't seen a patient with serotonin syndrome, but it is described in literature. So what are the symptoms by which you can recognize serotonin syndrome? The patients can have cognitive changes, autonomic instability, and neuromuscular changes. The cognitive changes include agitation, restlessness, confusion, lethargy, and nausea, vomiting, diarrhea, tachycardia, and increased temperature. Then neuromuscular changes like tremor, cogwheel rigidity, seizures, and can lead to respiratory failure. But what you have to understand is if you are putting a patient on methadone, and the patient is on these medications, and you see that patient is a patient who comes with restlessness. When you examine, there is hypothermia, patient has tremor, then it has to trigger whether is this a serotonin syndrome. Even though it is very rare, it can happen. So just understand that there is a possibility that it can produce serotonin syndrome in a rare patient. So the next clinical impact is the action on human either agogo related gene, which I have already told that it is abundant in myocardium. So when it blocks HARG, it produces or increases the QT interval, and it can lead to fatal arrhythmias, which like Torsades de Pointes, and which can cause sudden death. So this is one of the most feared side effect of methadone, and this is why many of the doctors don't use methadone. And I have even had that some people take classes on methadone, but they advise the students not to use methadone. But here we are looking at side effects as well as the beneficial effects of methadone, so that we can use methadone in a beneficial way for appropriate patient. So there are many cardiac risk factors. This include electrolyte abnormalities. So calcium, potassium, and magnesium. And older age, female gender, any heart disease, and the previous history of corrected QT interval more than 450 milliseconds, heart failure, malignancy, peptic ulcer disease, and increased doses of methadone. All these are cardiac risk factors. So there are many risk factors which you can see here. Okay, so even though we talked about fatal arrhythmias and Torsades de Pointes, increased QT interval, so all of you might be thinking, is it going to produce severe arrhythmias and Torsades de Pointes when we use it in patient? So there is one study from MD Anderson Cancer Center in which they did a prospective study in 100 cancer patients, and they monitored the QTC, that is corrected QT interval, when patient was started on methadone, then again at 2 weeks, 4 weeks, and 8 weeks. But what they found was there were no clinically significant events that occurred. There were no deaths or there were no ventricular fibrillation, Torsades de Pointes. And what you have to understand this, in this study, they used less than 40 to 50 milligram of methadone. So this is one study which says us that if you use a methadone in an reduced amount, like less than 40 milligram, it is very unusual to produce serious problems like ventricular fibrillation and Torsades de Pointes. And there are many medications which can cause increased QT interval. So these are medications which themselves can cause increased QT interval. And if you add it along with methadone, then the chance of QT interval prolongation is more and can produce Torsades de Pointes. So what is important here is you can see there are many drugs which is included under the category risk, and please see the medication under that. You can see most of the medications are that which we commonly use in palliative care. You can see there is ciprofloxacin, azithromycin, erythromycin, fluconazole, levofloxacin, citalopram, haloperidol, ondansetron. So these are all medications which we commonly use in palliative care. So when you start a patient on methadone, you should go through all the medications and see whether there are any medications which has higher risk of producing QT interval and toxodepoids. Um, sorry. Okay. So we will move on to the pharmacokinetics of methadone. What is the oral bioavailability of morphine? Anybody please tell me what is the oral bioavailability of morphine? Anybody? It is only 20 to 40, 20 to 30%, or even some literature says it's 10 to 20%. That is the fraction of administered dose which is available in the systemic circulation for action is known as bioavailability. Bioavailability and absorption, these are two different types. Morphine is 100% absorbed, but bioavailability is only 20%. So that's what 20% of morphine is available on unaltered in the blood for action. But in case of methadone, you can see the bioavailability is high. It's about 80%. Morphine is not usually administered sublingually, but you can see here methadone can be administered sublingually, and it can also be administered parectally. We know that in patients who are unable to take orally, you can administer morphine parectally. So likewise, methadone can be administered parectally. And after absorption, metabolism happens. Metabolism again takes place in liver, but there are a lot of enzymes, cytochrome P enzymes involved in the metabolism of methadone, and it is mainly excreted by bowel, and a small percentage is through kidney. So methadone is supposed to be a safer medication in patients with renal failure. So this is important. What happens after administration of methadone? Okay, so you can see here when you administer methadone, it will be there in the blood for up to 2 to 4 hours. So I am talking about a patient for whom we are administering methadone for the first time. So you will see, or there will be some effect due to methadone for the first 2 to 4 hours. And immediately after 2 to 4 hours, this methadone will be disappearing into the tissue binding sites. So all of the methadone will be going into the cells where it will get it will be binding with the tissue binding sites. And once this tissue binding sites are saturated, you can see here, here the tissue binding sites are saturated. Once it is saturated, then a small fraction of methadone is liberated into the systemic circulation. And this small fraction will be continuously liberated into the systemic circulation, which will give pain relief. So for the tissue binding sites to get saturated, it will take about 5 to 7 days. Okay. So that means up to 5 to 7 days, the patient may not get sustained pain relief, even though there will be some pain relief during the first few days. I told you that up to 2 to 4 hours after each administration, the methadone will be there in the systemic circulation. So after that, immediately it disappears into tissue binding sites. And once it is, the tissue binding sites are saturated, a fraction will be liberated into the systemic circulation. So this process will take 5 to 7 days. So unlike morphine, where we can increase the dose of morphine every 24 hours if you need it, but methadone, the dose can be increased only after 5 to 7 days. So this is the importance of distribution of methadone. And I told you metabolism mainly happens in liver, and there are a lot of cytochrome P enzymes involved. So you can see here cytochrome 2b6, which is the major cytochrome enzyme involved in the metabolism. But there are other cytochrome P enzymes involved. So you know that many drugs are metabolized in liver. So these drugs will have some interactions with methadone because methadone is metabolized by many cytochrome P enzymes. So please see that there are cytochrome P inhibitors as well as cytochrome P inducers. The medications like protease inhibitors. What are protease inhibitors? Anybody? These are medications used to treat HIV. Okay. So protease inhibitors, azole antifungals. So our fluconazole, ketoconazole, etc. Then cimetidine, cyclosporin, macrolide antibiotics, azithromycin, erythromycin, clarithromycin, those group of medication. Amiodarone and non-DHP calcium channel blockers. All these are strong cytochrome P inhibitors. So when you give this medication along with methadone, the effective dose of methadone in the blood will be increased. Okay, so you can expect toxicity if you continue to give fluconazole to a patient who is already on methadone. The blood level of methadone is going to be increased because there is this cytochrome P is inhibited by fluconazole. So methadone level in the blood is increased. So it can cause toxicity. So in such situation, either you can give fluconazole maybe 75 milligram one stat and see whether the oral thrush is responding, and maybe after 3 or 4 days you can again give another 75 milligram. Otherwise you have to use another medication which doesn't have much interaction with methadone. And instead of macrolide antibiotics like erythromycin or clarithromycin, you give amoxicillin, which doesn't have much interaction with the methadone. So this is something which you need to be careful. And there are cytochrome P inducers which can reduce the blood level of methadone. You can see phenytoin, phenobarbital, oxcarbazepine, rifampicin, carbazepine, St. John's wort, etc. And when these medications are given along with methadone, sometimes it can cause withdrawal symptom of methadone because effective methadone level is reduced. So it can produce withdrawal symptoms. So watch for withdrawal symptoms. And if there is withdrawal symptom, you have to give more methadone. And these are medications which can cause either increase in the level of methadone or reduction in the level of methadone. So see here, many medications which we again use in palliative care very commonly. Ciprofloxacin, clarithromycin, erythromycin, fluconazole, ketoconazole, clopidogrel, amitriptyline, escitalopram. So all these are medications can increase the methadone levels in the blood. And on the right hand side, you can see the medications which can decrease the methadone levels. So this medication which I have described here These are the most important or most potent inhibitors or inducers. But there is an extensive list of medication which can either reduce or increase the level of methadone. So now we are moving on to for which patient we can start methadone. So methadone is used as an adjuvant. So can anybody tell me what is the definition of an adjuvant? Anybody?
Adjuvants are
Yeah. Dr. Sheena?
along with analgesics, other drugs like antidepressants or are given to reduce the pain or to other side effects, other associated pains like neuropathic pain or
Yeah, you are correct. I will put it in another way. So medications which are not primarily indicated for analgesia, but is helpful in some painful condition. So medications whose primary indication is not pain relief, but is helpful in some painful condition are known as adjuncts. So as you told, tricyclic antidepressants. What is the primary indication? Is to treat depression. But when it is used in neuropathic pain, it produces pain relief. So it becomes an adjunct. If you look at that way, methadone itself is an analgesic, isn't it? It is primarily an analgesic. But in literature, it is said that methadone is used as an adjunct. But that is, they describe adjuvant in case of methadone when methadone is used in small amounts along with other opioids. Suppose a patient is on 10 milligram of morphine 4 hourly. Patient has got good pain relief most of the time, but at night patient has pain. Otherwise, he is stable. So if you add a 2.5 milligram of methadone at night, the patient will have good pain relief. Or else 20 milligram of morphine every 4 hourly, or 50 milligram of morphine 4 hourly, along with the 2.5 milligram BD or TID of methadone. So that patient will get good pain relief. So that's how methadone is described as adjunct. It is not like the other adjuncts which we usually see, like tricyclic antidepressants or anticonvulsants. So when methadone is used along with other opioids in small amounts is what is described as an adjunct here. Then another indication would be many of you might have had this experience when you treat the patient with methadone or fentanyl. There are some percentage of patients who doesn't get proper pain relief, and you might have had a very tough time. And in such situation, if you convert that into methadone, then most of the patients can get good pain relief. And if the patient is coming with significant renal problems, increased serum creatinine, now it's 3.5, and you might be having some concerns regarding morphine because it accumulates in renal failure. But in such cases, you can convert that into methadone. And if the patient is on high doses of opioids, like 100 milligram of morphine every 4 hourly, or 50 milligram of morphine 4 hourly, then probably you can convert it into methadone. And some patients may have very serious side effects. It is not controlled with our usual medications. Suppose the patient has vomiting, which is on morphine, and not controlled with haloperidol or metoclopramide, then maybe probably you can convert it into methadone. And patients with allergy to other opioids like morphine, fentanyl, then methadone is another choice. So these are the indication to start a patient on methadone. And is there any contraindication? So these are some important points that you have to remember about who are the inappropriate candidates. Patient with family history of sudden unexplained death. So if there is a patient who suddenly died without any diseases, then you have to think that whether it is due to congenital QT syndrome prolongation, which can run in families. And if you see that a patient who comes with an ECG, who has a corrected interval, QT interval of more than 500 milliseconds, then a patient who has dementia and unable to understand what you are talking, then it will be very difficult for us to titrate methadone, and you are unable to follow up the patient if the patient is having severe pain. And methadone is not a good medication to titrate, because during that time we should start the patient on short acting medications like morphine, so that we can give immediate pain relief, and then at a later time you can convert it into methadone. But for acute pain crisis, it is not usually advised to start a patient on methadone. So when you start a patient on methadone, how are you going to monitor the patient? So this is important. So basically, what all investigations should we do? It depends on goals of care. Suppose we have a patient who is getting curative chemotherapy. So for that patient, we have to do all the investigations. But if the patient is only for comfort care, a patient with stage 4 a small cell carcinoma of the lung with multiple liver and bone mets, that patient is not fit for any chemotherapy or radiotherapy. So in such patient, they are patients who are only for comfort care. In such patients, we need not do any investigations. But otherwise, if the patient is undergoing any palliative or curative oncological intervention, we should do some baseline investigations like ECG for monitoring the corrected QT interval and electrolytes, which I have already told you: calcium, potassium, and magnesium. And once you get a ECG, when you start the patient on methadone, then after 2 weeks, you can again do an ECG to see whether there is any QT prolongation. And you titrate the methadone and you reached up to 30 to 40 milligram, then you again do another ECG. And when it reaches 100 milligram, another ECG to check for QT interval. And if you think that, okay, I have added a medication which can increase the QT interval, then again you can take an ECG. So this is how you have to follow up the patient, and these are the investigations, ECG and electrolytes. These are the basic investigations that you have to do while you start patient on methadone. But please understand that this investigation should depend on the goals of care. And I already told you that methadone will take about 5 to 7 days for sustained pain relief. So that's the time where methadone will be constantly liberated into the systemic circulation. So that's why it takes up to 5 to 7 days. We talked about the saturation of tissue binding sites. Then only the methadone will be liberated in the systemic circulation. And if the patient is elderly, or if the patient has hepatic impairment, it is better to wait for 10 to 14 days before you increase the dose of methadone. So these are the two preparations available in India, tablet as well as syrup. Tablet is 5 milligram, and syrup, it contains 5 milligram in 1 ml. Okay. So it is RMeth. That's the trade name. Only one pharmaceuticals produces methadone in India. That is Rusal. And now we are moving on to methadone conversion. How can we convert a patient from another opioid to methadone? Suppose a patient is on 400 milligram of tramadol or 300 milligram of tramadol. How much or what would be the dose of morphine if you want to convert this patient into morphine? 300 milligram of tramadol, you want to convert it into morphine. What would be the total dose of morphine? Anybody?
Same dose?
400 milligram? Sorry, 300 milligram?
Yes. Yes, sir.
Okay. Anybody else? So what is the potency of tramadol? Potency of tramadol compared to morphine?
It is 1/3 of the morphine.
It is 1/10. 1/10.
Okay, 1/.
So 300 milligram of tramadol is equal to how much milligram of morphine? 300 divided by
30 milligram.
10. That is
30
30
milligram.
milligram. Okay. So if I ask you 500 milligram of tramadol, it is equivalent to 50 milligram of morphine. 100 milligram is equal to 10 milligram of morphine. But this is not applicable in case of methadone. It doesn't have a linear relationship. Depending on the dose of morphine, the dose of methadone will vary. I will show you some examples. Okay. So this is one of the conversion methods, which I think is very simple and easiest. There are many methods available in literature, but when this paper was available in 2019 by hospice and palliative care physicians, this is a consensus white paper developed by hospice and palliative care physicians. So according to this conversion factor, if the patient is taking less than 60 milligram of oral morphine equivalent per day, the initial dose can vary between 2 to 7.5 milligram per day. So if a patient comes to you with maybe 30 milligram of morphine, then you may convert it into 2 to 7.5 milligram of methadone per day. But if the patient is taking oral morphine equivalent between 60 to 199 milligram, and if the patient is less than 65 years old, the conversion ratio is 10:1. So if the patient is taking 120 milligram of oral morphine equivalent, what would be the equivalent methadone dose? And patient is 40 years old. What is the equivalent methadone dose?
12.
12. Yeah. But if the patient is taking more than 200 milligram of methadone, or if the patient is more than 65 years, the conversion ratio is 20:1. So this is what I told you. The conversion from an opioid to methadone is not linear, but it is linear in case of other opioids. We used same potency when converted, when tramadol is converted to morphine, or when fentanyl is converted to morphine. We can use the same potency, but here, according to the dose of morphine, the the potency of methadone varies. Okay. And when you can increase the dose of methadone, it is only after 5 to 7 days. And how much you can increase? If the patient is taking less than 30 milligram per day, you can increase 5 milligram per day and wait for another 5 to 7 days before you increase. If the patient is taking more than 30 milligrams, you can increase 10 milligram per day and again wait for 5 to 7 days before you increase. Okay. And now we are moving on to some examples. So this is a 37-year-old man who had a carcinoma of the buccal mucosa with another second primary papillary carcinoma of the thyroid, for which he underwent surgery and radiation. And in 2019, he had a level 2 nodal recurrence for which he underwent surgery. But then his main problem is severe pain. You can see the patient who is sitting with severe pain. He describes pain which start inside the left ear and going on to the lateral side of forehead, then to submental region. They describe it as a pricking type of pain and scores 10 by 10. So you can see this is mostly in the mandibular nerve distribution area, the pain which he describes. And because of this patient underwent mandibular nerve block 3 times, but there were no pain relief. And then this patient was started on injection morphine, but had severe toxicities. So they stopped it and started on morphine like this 10, 15, 10, 30 and 10 milligram SOS. Even with this dosage, the patient had toxicities of morphine. And they also tried him on various adjuvant analgesics like tricyclics, pregabalin, etc. But there were no pain relief. And this patient, when he visited us, was on these medication, morphine, and like this, pantoprazole, ciprofloxacin, escitalopram, serratiopeptidase, diclofenac, paracetamol. So is this a candidate for methadone? What do you think?
Patient is 67 years old.
Hmm.
So we can start in the ratio because more than 60, we have to start 10:1. So total dose is around 75, 65. So 6 milligram methadone.
Okay. What are the indications to start methadone in this patient? We talked about the appropriate candidates for starting methadone. So what are the indications or what are the points which tell you that, okay, this patient is appropriate for starting methadone?
Pain is refractory to other.
Yeah, pain is refractory to other opioids. Yes. Anything else?
As an adjuvant, we can use it.
Okay, as an adjunct, you can try then.
Opioid switching.
But we are talking about the same thing. Pain refractory to other opioids, we are switching it to other opioid. What is the type of pain here? Is it a neuropathic pain or nociceptive pain or mostly mixed pain?
Must be both.
So both neuropathic along the mandibular nerve.
Yeah, it's mostly neuropathic pain because you can see it is mostly distributed on the mandibular nerve distribution, and he described it as pricking type of pain. So we told that methadone will be useful in treating neuropathic pain because of its NMDA antagonistic action as well as tricyclic antidepressant like action. So that may be another indication. What else? Toxicity, isn't it? Patient is on morphine but has toxicity. That's also another indication to start methadone. So it's complex neuropathic pain, morphine toxicity, refractory to other opioids. So what would be the, okay, so now we understand there are some indication to start methadone. But before starting, what all should we do? Do you need to do any investigations?
Baseline ECG, electrolytes, family history.
Yeah. So first, I think you can ask about any family history of sudden unexplained death. Okay. And another thing which you have to ask is there any reliable caregiver to administer methadone? So these are two questions which you have to ask to every patient for whom you are going to start methadone. And whether ECG and electrolytes need to be done, I told you it depends on the goals of care. This patient has two primary malignancies and which is not responding to any treatment. So this patient is only for comfort care. So actually we need not do ECG or electrolytes, but if you are not confident enough, you can do a baseline ECG and electrolytes. Okay, so these are the present medication the patient is taking. Do you have any concerns with these medications when the patient is, when you are going to start methadone?
Escitalopram.
Okay, anything else?
Along with morphine, we have to prescribe for constipation also.
Yeah. Anything else?
And adjuvant,
Fluoxetine also is chondroin.
Which one?
Ciprofloxacin.
Yeah. So you can see ciprofloxacin, escitalopram, all this can increase the QT interval and as well as increase the methadone levels. Okay, and pantoprazole is also one medication which can increase the methadone level. Okay, so escitalopram, pantoprazole, and ciprofloxacin. Okay, now you have to calculate the dose of methadone. What is the dose of morphine she is taking? 65 milligram, isn't it? So she is taking 65 milligram. What is the age of the patient?
37.
37. So what should be the conversion ratio?
10:1.
Yeah, 60 to 199. Oral morphine equivalent 60 to 199, and the age is less than 65 years. Then the conversion ratio is 10:1. So it should be 6.5 milligram. So the duration of action of methadone is 8 to 12 hours. Okay. So morphine we have to give every 4 hourly, but in case of methadone, you need to administer every 8 to 12 hours. So you can administer this either as suppose if you have only a tablet, then you have to give it 2.5 milligram BD. That is 5 milligram. But if you have syrup methadone, then you can administer it 2 milligram TID or 3 milligram BD. So I told you that it will take about 5 to 7 days for sustained pain relief. So till that time, what should we do? You have to continue morphine. Okay. It is not 4 hourly basis. It is on a 4 hourly SOS basis. That means when you administer methadone at 6 a.m., you give 3 milligram of methadone. And at that time, you will ask the patient, do you have pain? Patient says, no, I don't have pain. Then you will not give methadone. At 10 o'clock, you can ask the patient, Do you have pain? Patient says, no, I don't have pain. Don't give morphine. Then 2 p.m. Patient says, I have pain. Then you have to give morphine. 6 p.m. patient says, I have pain. Give morphine. 10 p.m. No pain. Don't give. So that's what Q4 hourly SOS basis means. It is not Q4 hourly and SOS. It is Q4 hourly SOS. Okay. So what should be the prescription? It should be tab methadone, then tab morphine for hourly SOS, and paracetamol was added. Instead of ciprofloxacin, amoxicillin was added. Escitalopram was taken out. Actually, this patient was not depressed. The treating team added escitalopram because there were no pain relief. They thought that it is because of depression. This patient had severe pain, and they added escitalopram because pain was not responding. So this patient had very good pain relief after starting on methadone. This is another patient, again a 39-year-old woman with carcinoma of the pancreas, stage 4, liver, lung, and spleen metastasis. She received 5 cycles of chemotherapy, but oncologist told them that the disease is not responding and you have to stop the chemotherapy. So she was receiving palliative care from the oncologist. You can see the pain which starts on the left lateral aspect of the chest and abdomen and goes to the back like a band. And most of the time, the pain is 10 by 10, varies between 8 to 10 by 10. She described it as stabbing pain. And patient is taking morphine, tramadol, and paracetamol, which reduces her pain from 10 by 10 to 8 by 10 for some time. And you can see the patient has myoclonus. These are the medication which she was taking. Tab morphine 20 milligram, 6 hourly. Injection tramadol 100 milligram IV TID. Injection paracetamol 1 gram, 6 hourly. Tab gabapentin 100 milligram TID. Amitriptyline 25 milligram HS. And bisacodyl 5 milligram 2 HS. So is this a patient for whom you can start methadone?
Yes.
Yes,
What are the indications?
going towards morphine toxicity.
Yes, morphine toxicity.
Still patient having severe pain.
Hmm. Okay. Anything else? So this patient is on 2 opioids, isn't it? And there is no pain relief. So pain refractory to other opioids. And probably it's a neuropathic pain. So these are all our indication to start methadone in this patient. So do you need to do any investigation in this patient? Not really, isn't it? Because she has stopped all the oncological interventions because the disease is not responding. So what is the dose of, so you have decided to start methadone. So what should be the dose of methadone in this patient?
So
Please
same 10
calculate.
is to 1. Was less than 60 years old.
Okay, please calculate.
39 years.
What should be the dose?
We have to take in account the tramadol also. One tramadol 100 milligram.
Okay. So please calculate.
Okay. 80 mg morphine plus 300 mg tramadol. It's around 11 milligram of methadone.
11 milligram of methadone.
So we have to start with the 7.5.
7.5 total dose.
No, so 7.5 to LR.
That is 15 milligram.
Acha.
She's taking equivalent of 110 milligrams of morphine. So, so it should be 11 milligram of methadone.
Okay. So let's see. So he's taking 80 milligram of morphine. That is, he's taking 20 milligram 6 hourly. So it's 80 milligram. Then he's also taking tramadol. So you have to remember that you have to convert all the opioids into equivalent doses of morphine. So here patient is on tramadol. So that also you have to convert it into morphine. So total tramadol equivalent would be 30 milligram of morphine. Then total oral morphine equivalent will be 110 milligram. And as this patient is taking between 60 to 199 milligram, and age is less than 65, then the conversion ratio is 10:1. So that is 11 milligram. So you can start with tab morphine, tab methadone, 5 milligram BD. So do you have any concern with any of the medication here?
Amitriptyline
Yeah.
plus amitriptyline.
Yeah, amitriptyline can actually increase the dose of methadone. But this is not a high dose, isn't it? 25 milligram is very small dose. Either you can stop it, or if you think you can continue also. But when you start it for the first time, you should be cautious about all these medications. Once you are experienced, then you will understand which all medication need to be stopped and which need to be reduced, etc. So this patient was started on tab methadone 5 milligram BD, then tab morphine 20 milligram Q-Farachon and SOS versus tab paracetamol, gabapentin, and amitriptyline was continued. Bisacodyl 5 milligram 2HS. So this lady was she was a mother of 2 young kids, and she was in very severe pain. And she was telling that she is unable to do anything for her children and her husband. She was bedridden. And after starting methadone, she had very good pain relief. And actually, for the 2 months after this, she lived, she had a very good quality of life. She was going out, doing many things. She was finishing all her works. So she was very happy because after starting methadone, she was able to do all the things which she wanted to do for her husband and children. But after 2-3 months, this patient died. So this is another patient, a 40-year-old man with advanced malignancy of the lung, and he had spine metastasis, and he had a spinal cord compression at T2 level, for which he underwent palliative radiotherapy. But this patient had a very severe burning pain on both lower limbs, which was continuous 9/10. The patient is on following medication: tab morphine 40 milligram 4 hourly, tab amitriptyline 25 milligram 3 HS, tab pregabalin 150 milligram BD, there were no pain relief. Suppose you want to convert this patient onto methadone, what would be the dosage?
The 12 milligram PD.
12 milligram. How did you calculate?
Sir, every 4 hourly, so 6 into 40 is
Hmm.
equal to 240
Hmm.
and divided by 10. So to total 24. Then we have to give BD, then 12 milligram BD.
Okay. Anybody else have any other answers?
40 divided by 20. That's what she's-
It's 40 years old, na? Less than 60 years, I believe.
Yeah, but he is more than 200. If he's taking, then it's divided by 20.
Okay, yes, I forgot that.
Yeah. So the conversion factor is actually 20 because this patient is taking more than 200 milligram of methadone.
Then it should be 6 milligram.
So you can give syrup methadone 4 milligram TID or a tablet 5 milligram BD. Okay. And you have to give morphine on an SOS basis. And he's taking 25 milligram of 75 milligram of amitriptyline. So I think this might it might be better to get an ECG to see what is the QT interval. And if it is okay, you continue with methadone. Otherwise, you have to reduce the dose of reduce the dose of amitriptyline. So this is how you convert a patient from other opioid to methadone. And if you want to understand more about cytochrome P interaction, there is a website in which you can check. And medications, which all medications can produce QT interval. This is a website, credible-meds.org, which they continuously update. And there are apps available to calculate the corrected QT interval. You can download in your mobile and use it, in which you have to actually enter the heart rate and QT interval. And you click it, you will get a corrected QT interval. There are many methods by which you can calculate corrected QT interval. Okay. So in summary, methadone is a good analgesic if you use it in appropriate candidate. And it is an entirely different opioid from the usual opioids which we know, like morphine, fentanyl, tramadol, etc. Methadone, comparing to other opioids, you have to wait for about 5 to 7 days before you increase the dose of methadone. And there are many drug interactions which you need to be careful. And the dosage of methadone, it depends on how much oral morphine equivalent the patient is taking. And you should use methadone in appropriate patients. You should not be taken back when you see methadone, because this is what happens most of the time after understanding about the drug interactions and QT interval prolongation, torsade points. Many of the physicians are taken back. But understand that it is a good analgesic in appropriate patients, and most of the time you need not use more than 40 milligram per day. And another important thing is, even if the patient is on 1000 milligram of morphine equivalent, so if you calculate the equivalent methadone dose, it will be 1000 divided by 20, that is 50 milligram of methadone. But in never start more than 30 milligram of methadone in a patient, whatever be the dose of foreign morphine. So in 1000 milligram, start maximum 30 milligram of methadone. If the patient is 2000 milligram, then again you start on 30 milligram. It is 10,000 milligram, start on not more than 30 milligram. And um, when you increase the dose of methadone, you have to wait for 5 to 7 days. So these are some important points which I think you need to understand. Thank you.
Thank you very, very much, Dr. Sunil. Methadone is something which people have to be aware, and only by assurance from people like you, they will start to use it. Like I've used it in like when patients are on very high doses. So that's a different take. Okay, because for yeast, and then we used to monitor and give and those type of things. Just one little thing, your presentation was excellent. As always, you give so many examples. So all our participants should never have any fear, because they have themselves calculated and gone through the whole session with you. Just one thing, with the so many patients you see, how often are you using methadone in your practice?
So I think at a given time, we have about 5,000 active patients. And methadone was actually available in India in 2018. And that's when it was available at our institute. But we were very much afraid to start a patient on methadone, even though we understood how to start methadone. We had some backup from US, but during that time, from January to December, we started methadone only in 7 or 8 patients. But next year we started methadone on about 20 patients. 2019 and 2020 it was about 50 patients, and then I think now maybe at least 100 patients will be on methadone. So that's how when you are confident, then you will understand which are the patients. And so when we see a patient who doesn't have proper pain relief on another opioid, we switch over to methadone. And in patients who have difficult pain, methadone is another choice. So maybe maybe at least a patient in 2 weeks.
That's very good, because we do see, like, why I asked this question was, I used to see some patients like stump pain in Cancer Institute. So they would have had surgery. And then if they are young also, and then the amount of morphine they use, then you go on to sustained release, 30, 60 BD of sustained release. Like that, it's very common. And then on top of that 60, they'll be consuming another 80 or something of breakthrough pain morphine also. So in those situations, it will be helpful. And now, as you're telling, when the availability is there, it's always worth. End of the day, if they're going to get good pain relief, it has to be done appropriately. And this QT thing is there in so many things. As you said, so many antiemetics. We use many right, left, center in our other general practice, not knowing the seriousness of QT. Or I won't say not knowing, in some way. So like that, it's understanding and evaluating is what will help us. And then very slow, you've given such a good method of doing it. So constantly you keep observing the patient and family history. Those things are very important. This sudden death and things in family history is what will open up the information for us. So always, as always, history taking is essential. We don't forget our roots of medicine. Okay, well, let us leave it open for the team to ask if either you, all of you have been quite interactive during the session itself. If anyone has any specific queries please unmute and ask, speak, or you can type in the chat also, whichever is comfortable for you.
I just want to ask if it's more than 200 milligram of morphine they're taking, we should divide by 20. Is it because if you take higher amount of methadone, it will cause side effects? Or what is the why? Like when you're taking higher morphine, you want to take lesser methadone compared to less than 200.
So it is probably, there is no explanation, but it is probably due to the NMDA antagonistic action. So we told that when the patient is on higher doses of opioids, it is because of the development of tolerance. So when you give methadone, that tolerance will be reversed.
Yes, the mechanism of action of methadone is what is the factor in that. That's what I too thought. Thank you. So because when it has such a effect, like additive, synergistic, so many things are there, no different. When you go into pharmacokinetics, so many types of actions are there. So that NMDA part is one of the important thing. So why are they not getting the relief with higher doses of morphine? Tolerance is the factor. When that is taken care of in this, that could be one of the reasons. As he said, I'm also not aware of any exact reason for it, but probably like we say by exclusion. So when you say something, that's how for many situations, solutions are achieved, either by direct explanation or by exclusion. So this could be one of the reason why that could be the reason for dividing it by 20. Could anything else anyone would like to ask? So by the way, this is our final session. And so anything else, yeah, if you could, with Dr. Sunil's permission, maybe they could express what is their feeling about the whole program, how effective or how informative they found the whole program to be.
If there are no other questions on methadone, I think this is the time where you can give feedback so that not only the good points, but also some negative points so that we can improve on for the next session.
Exactly the same thing, only I had messaged to all of them also. See, we want their feedback. Why? For two reasons. One is for us to know what needs to be changed. And then for the next program also, we can make the changes and implement it. And that is what positive criticism, negative criticism for the development is always beneficial. So please open up and say, what is that you would like us to change or add or something like that, so that many more batches will be benefited. And today, many of you have not got your videos on. Either everyone is very busy or whatever it is. Would be nice to see all of you, I thought.
You have a couple of chats coming in.
Okay, let me read them. Interactive, informative.
Ma'am, I'm working in a rural area in Jharkhand. So we have come to this place some years back. So actually, I found this course through Dr. Ashrita, and that's how I joined here. So it's a very useful course I really want to mention. Only one thing is like, if at all in future, in our hospital, if you're planning to start up, then if we need some help, so whom should we get in touch with, and those things I need some help.
Yeah,
So,
definitely. So
Dr.
one of
Sunil will
our,
go ahead.
yeah, one of our aims to do this course is to facilitate or to relieve the suffering of people all over the world if possible. But definitely, our national state facilitation team is working in many states. So Sripriya, I think you can please take her number and name so that we can get connected to one of our state facilitation team.
Sure, sir. That will definitely be done, Dr. Divya.
And one more thing which I want to add is, if you have any difficulty in accessing opioids, we are ready to work with you so that the state drug controller or whoever be the person in charge of opioids will be working with you to facilitate you to get recognized medical institution status. So if any of you can contact us, we are ready to help.
Okay, thank you so much.
See, that
And
go ahead.
yes, ma'am. And these videos, I can access it and see the material anytime, or I need to download and keep everything just for reading and for go through it
As of
again.
now, the materials uploaded in IAPO are having free access anytime. The technical team has said that it would be accessible anytime. So it is like you can definitely log into your IAPO account and access them anytime. But then we would also suggest you to keep a backup by downloading them and keeping it somewhere in your drive as well, so
Right.
that in case any technical glitches happen, you will have a copy.
Okay, thank you.
See, as I mentioned in the outset of our session today, see, it's I'm spellbound to say, I would say, because from day one to today, everyone who has come and all the faculty have told you and invited you with open arms, telling that we are there to help you. Okay, from the management team person Aarti, or the medical team Dr. Sunil. So please, anywhere, see, each one of us, see, like 30 of you who are there, all 30 of you will not have the same intention or same goal or same objective. 30 will have 30 different objectives. We are all made different. There is some benefit in that also. So each one of you, and don't feel belittled or anything. Oh, my doubt is very small. They will not, nothing like that. Only if you ask, you will know. So as the whole team is willing to help, so please, as and when you need, please get in touch. And one thing I would say, always prepare yourself, plan ahead, foresee a little bit. So if you do all that, the main beneficiary is you. So you will not be stressed. So little bit foresee stuff, what you want to do. This is what I'm thinking. So just think, go talk through what all you would anticipate, and then get in touch ahead, so that at the time of crisis, oh, I don't know anything. See, in spite of that, if you have crisis, you call, they're going to help. And also they told you that there is a everyday helpline, everything is there. So ask me anything, there is some solution. It's not that common to find something like this. So feel free and get in touch as and when required, as you go through your career or your project or whatever you're willing to do, and then get in touch at the appropriate time and be benefited.
Dr. Triveni here.
Yes, please.
By profession, I am a microbiologist teaching faculty in a private medical college. So when I came to know, and I was a little interested, like not for a treatment purpose, but I want to do a trust later through which I can help the people mainly concerned, not only the higher who can pay, they have a lot of options, but people who can't afford. So that was my whole point in the taking this course. I want to know how it works, because I am a microbiologist and I have lost touch, clinical touch for almost many years, almost 20 years. But when I first took the course, I was little concerned like how much I'll able to grasp, because I have left clinical medicine long time, because we are mainly dealing with the infective cases and infections and all those things. But really the every sessions, the sessions were so, it was like for a MBBS, I became an MBBS student. I went to that level, so I could understand. So it was really good. And ma'am, especially how you explain end of that, that gist, that what is there. So I'm a teacher, but I feel we are privileged to know you, to listen to you. And one more suggestion, I feel I have been always asking, can I visit Pallium India or anything, so that is it possible that in this course also in the future there's a provision, if anyone wants, they can visit, like maybe my thought, they can visit and more beneficial when you see, because I'm not from that background, like I am different totally, microbiology. And my thought, ma'am, just for all
Everyone, don't ever
Thank you.
think like that. See, it's only team working, okay, regarding visiting. And thank you very much. See that we are all, I would just say I'm doing my duty, okay? That's what each one of us have to do. We have to do God's justice to whatever we do, 200% in anything that you do. Okay, visiting and things is really very helpful, because all of us have to see to believe. So for that, I would say Dr. Sunil and Dr. Sunil will be able to guide you and see how it works. And Sri Priya will be able to give you the contact to get in touch with whom to get in touch to do a visit and see things. Is that right?
Yeah. So if anybody want to come and have an observership for a few days, you can actually ask Sripriya, so that she can get you connected with the right person.
Yes, it's
yeah.
helpful for us, I believe, at least
Yeah.
after this course, after learning so much. And then, so that's my thought.
So that's one of the problem with online sessions. We don't have the hands-on training. So many candidates, many participants actually ask for observership. So we also facilitate that. Sometime, if possible, it may be near to your home, if there is some palliative care units available, and if there are good practices, we can direct you to there. Otherwise, you can even come and visit us at Trivandrum.
Okay, thank you, sir.
Taking
One
up
of you are
Dr. Akshita, taking up Dr. Akshita's query as well along with this, yes, the doors of Pallium India is open to all who are interested to learn more about palliative care, to get hands-on training. The doors of Pallium India is always open at Trivandrum. And for those who could not make it to Trivandrum, we do have hands-on training collaborators all over India. The list will be shared tomorrow or day after tomorrow positively in the group. We do have around 52 sites where they provide hands-on training in collaboration with Pallium India. The list will be published in the group. You can go through that. You can identify which site very nearest to you is providing hands-on training and get in touch with them. And we do facilitate that. For visiting Pallium India, yes, of course, you can just leave a message to us. The overall procedure is being kind of coordinated by Ms. Arati Venukumar, whom you are familiar with, the part of our state facilitation team. You can get in touch with her directly or through me, the coordinator, and we will definitely help you out.
Exactly true, Sri Priya. The management session that we had, the whole of India, like 4 regions, whichever region you are, don't worry. You as long as you're there, you get in touch with the concerned team, and all 4 stalwarts, she has said. And then they've done so many advances and they're actively working on it. So what more you need? So don't think that you're far away. There's nothing like that. If you think you want to do, and there is a way to it. So that is the attitude and interest, enthusiasm. Those are the things which are needed. And then everything will fall in its place. Thank you very much. So anything else, like as Dr. Sunil asked, you also have to tell us something else which, if you think that we need to change or do something different for the benefit of everyone. Okay, even if you are not telling now, please send your feedback.
Thank
Please put in words what you feel, what needs to be added on, or anything like that. It'll always be nice to improve and get better day by day.
Ma'am, the classes are very useful and it is very interesting. I stay in Trivandrum, so definitely I'll make a visit to Pallium, India. Thank
Very
you so
good.
much.
You're always welcome, ma'am.
Thank you. Thank
Okay,
you.
Sripriya, I think I'll hand it over to you. If Dr. Sunil is also happy to go ahead and.
I do see query regarding certification from Dr. Deepthi. We would take it up in WhatsApp group or maybe in personal chat after this session, because it is like I would have to say more about regarding that. So I will definitely leave a message in the group regarding the certification process today evening or tomorrow. Anything else? Any words from anyone? Just
I just
giving
want to say thank you, Pallium India, and thank you, Radha ma'am, and even Shripriya ma'am for conducting these classes so nicely. And I think each and every class was well structured. Most of the topics in palliative covered, and we got a basic idea of what palliative medicine is, and how each one of us, no matter what background we come from, can contribute to palliative medicine. And also we found out that there's a long way to go, but if we are determined, definitely a lot of changes can happen. I'm actually currently working in a perinatal palliative service in a women's department, and I think for me, palliative medicine in itself was very new, and then there was pediatrics, and now in perinatal, I didn't even know perinatal palliative medicine also existed. So I think it's a beautiful branch for any one of us to consider. And thank you so much, everybody, for joining. And it was a very good interaction also. And we got to know such eminent faculty, and a good exposure for everyone, I'm sure. And thank you, Shripriya ma'am, for uploading all the all the classes, and keeping us updated. That was really, really helpful. And you also gave us everything on time, and so that was very nice of you. And Radha ma'am, your advices and your after every class, whatever you told us, whether it was related to the course or even otherwise, sharing your experiences, I think it was very essential for us budding doctors. So thank you, everybody. And I wish everybody a very good luck, and I hope we can all meet once. Thank you.
God's grace and blessings to all of you. To God, I would pray to God that He showers His grace so that all of you are successful in all involved whatever you do. That's what. Be happy and put the effort, and then everything will happen. Thank you very much for all your feedback.
Thank you.
Sunil sir, I believe you were asking something to Dr.
Yeah,
Akshita.
I was asking Akshita, where is she working?
I'm actually based in Singapore right now. So I'm working in a women's hospital. It's called KK Women's and Children's Hospital. I started doing research here. So I got a chance to work in perinatal palliative care.
Okay, yeah. There are perinatal palliative care which has already been started in some places in India.
Oh, okay.
Yeah.
I didn't even know that it existed. I didn't even know that people opt to continue pregnancy despite knowing of a life-limiting condition. So this is very new, and it's very I think it's very beautiful to just be a part of palliative medicine. And this course has really helped me in many, many ways, just to brush up and learn so many new things. So thank you so much.
So before closing, Shripriya, I would like to thank Radha madam as she was there to take us, all of you, through all the 20 sessions. And I know that she has done her job very beautifully. And I think she also had the opportunity to take you as a group so that everybody is interactive. And She was like a mother figure to all of you. So thank you, Radha Madam, for that. And thank you, Sripriya, for beautifully coordinating this. And it's always like that. Sripriya does. This is not the first time for her. So she's doing coordinating for many courses. So thank you. And it was a privilege to have you all of us during the last 20 sessions. And we will, and another important thing is that in India, only 2% of needy or 2 to 4% may be getting palliative care. So by doing this course, we think that more people will be helped by each of you so that we can reach to the other needy person. So that's our vision to help the people who are suffering. Thank you.
Thank you very much, Dr. Sunil. In fact, it was such a pleasure and privilege for me to be part of the team. It was team working. All of us worked together. That is what, and I'm happy and thankful for all your kind words.
Thank you, everyone. Thank you for those valuable words. Yes, of course, if I could, like, whatever I did was just to facilitate the entire thing. Being a non-medical person, if I could ignite that passion, I could be part of that team which could ignite the passion in you to help the needy, to provide selfless care to the needy people. I would be the privileged one, apart from for what I am being paid for. So we do hope that this wonderful journey of us continues, because only the sessions have ended. We will all be active in the WhatsApp group. You can get in touch with us over WhatsApp, through IECO, or our email address anytime you want during the working hours. We would only be happy to help you out, to support you in all ways we could, so that you continue this journey. We all continue this journey of palliative medicine, this selfless care. So with that note, this is Sripriya, along with Dr. Sunil Kumar and Dr. Radha Venkatesan, signing off from the TIPSA cohort. See you everyone in some phase of life. With smiling face.
Thank you. Thank you to one and all.